Hey everybody, let's go through the pharmacology of migraines. So, migraines, there's a theory that it comes from serotonin, which is mostly made in the intestines, but that doesn't cross the blood-brain barrier. Important to know. There's 14 serotonin receptor subtypes. The most important ones are 1 through 7, and those are important because they work in the brain. So only 5-HT3 is ionotropic. The rest are metabotropic. So they're going to take a lot longer to work. And only 5-HT1 is inhibitory. So serotonin is going to be made directly in the neuron. It's going to be stored in vesicles, and VMAT2 is going to transport it into the vesicles. It's going to be released via exocytosis. Activation is when they bind to the receptor. And buspirone is going to be a partial agonist of serotonin receptor, and it's an anti-anxiety medication. Sumatriptan is a selective serotonin 5-HTD or 1D or 1B agonist, and that's used to treat the migraine. Cisapride and renzapride are selective 5-HT4 agonist, and that's a prokinetic for weak bowel, so IBS, Crohn's disease. Metoclopramide is a 5-HT4 agonist and a 5-HT3 and D2 antagonist used for anti-nausea. Ondansetron is a selective 5-HT3 agonist or antagonist, and it's first line to prevent nausea and vomiting in anti-cancer therapy. Clozapine has a high affinity for 5-HT6 and 5-HT7, and it's a 5-HT2A2C antagonist, and it works as a atypical antipsychotic. And then the SSRI, you know how that works, is fluoxetine. Okay, so migraines are usually unilateral. The ones that last more than 24, 48 hours. Nausea, vomiting, photophobia, phonophobia, and vertigo are the classical symptoms. Migraine with aura is also known as the classical migraine. There's visual or neurologic symptoms. Migraine without aura is just called a common migraine. How does it happen? We're not really sure. It could be a vascular theory where the vasoconstriction will cause ischemia, causing the pain. The neurogenic theory is because atypical spreading of cortical electrical activity occurs, and then from there that starts the vascular phenomenon. So this is just kind of like a combo. We all believe that it's a swelling of the neurons that causes a lot of pain, and from there is the high release of a serotonin, neurokinin, substance P. Substance P is our pain substance, so that's why it's important to note. And nitric oxide for the vasodilation. So we want to give ergot alkaloids, and that can cause dry gangrene of the hands and feet, but once we make it synthetically, ergotamine and dihydroergotamine are partial agonists at the alpha adrenergic and 5-HT1 and 5-HT2 receptors. So they constrict the dilated vessels and reduce the inflammation. So this is an acute treatment. Side effects, coronary vasospasms, chest pains, muscle cramps. So of course, with all of these, you don't want to give them to anybody with any heart problems, vascular problems, definitely not anybody in pregnancy that might actually induce the pregnancy. And hypertension. So this is not an ideal treatment. The selective 5-HT 1D 1B agonists, sumatriptan and rizatriptan, are going to prevent the vasopeptide release and induce the vasoconstriction. It's going to prevent substance P release in particular. So we use that for acute migraine or cluster headache attacks. Side effect, coronary vasospasms. So it's going to be contraindicated with anybody with like the cardiac arrest, like history, anybody with a princemental angina. Okay, so prophylaxis, propranolol. We give propranolol, a beta blocker, to prevent migraines. And there are a couple other like new shots, like funazarine is a calcium channel blocker. Other antidepressants can also work, but the most effective would be propranolol. Valproate and topiramate are going to be anticonvulsants, but they can also be used to decrease like the neurocortical activity. The most effective would be the monoclonal antibody injections. So sumatriptan can be also. This is not the monoclonal antibody test, but like treatment. But there's new ones that are out. They're expensive though, and propranolol is cheap. So we're going to try propranolol first before recommending the migraine injections. Sumatriptan is also used as a prophylaxis. Okay, so these are the classifications. Mild, you can treat with acetaminophen and NSAIDs. Moderate is going to be using NSAIDs along with alpha-tryptan or any of the ergot alkaloids plus an antiemetic. Severe is going to be treated with a alpha-atryptan or an ergot alkaloid along with NSAIDs and an antiemetic plus a prophylaxis. That's it for now. Thank you for your attention and good luck studying.